keep your microphone muted so that we don't have much background noise. Okay, so today, for the first half of webinar 4, we will be focusing on autism, children and young people, and we have Dr. Jenny Shaw, clinical psychologist, and GP Dr. Jessica Ong to talk us through this session, followed by David Rowley, who will take us through some top tips on the Mental Capacity Act and deprivation of liberty in practice. So if we go on to the next slide, Trang. Before we start the presentation, we would like to go through a quick Menti question. So if everyone could go ahead and scan the barcode on the screen. There's also a code if you wanted to go directly to the website, and I think Tom will share it in the chat box. So we'll give you a minute or so to do that, and then if Trang could just take us onto the Menti screen.
Brilliant, thank you, Ashika. I'll let us have a few moments just to scan or input in the code, and then I'll go into the Menti screen. Hopefully everyone has managed to do that, so. Yeah, so we're starting to get lots of people participating, which is really good. So the question is, how confident are you at supporting service users with autism? So we have not confident, little confident, some confidence, confident, and very confident. So far leading, we have 38% at little confident, and a little bit spread on from going from not confident to very confident. So it's reassuring that we have some people who are very confident and then others not. So at least then we're pitching to everyone, and hopefully you'll find this webinar useful. I can't really see how many participants we have, but so far we've had 16 people reply. Is there any more to come?
We've got about 32 on the call.
Shall I give it a little bit more time to? If anyone else wanted to add on to that. Otherwise, I'll move on to the next question. So, oh yeah, some more movement. So some engagement in terms of confidence, which is good as well. So I guess the webinar is as interactive as we can be. So it would be good, you know, to put in what you think, and be good to share across, you know, people who are not so confident with confident people as well. So what I'll do in interest of time, I move on to the next question, and if you, so it should then update your Menti. So the next question is, in the past, which teams have you liaised with to support service users with autism? So if you can, this is a free type question, so you can type in whatever teams or people or services that you have used to support your service users and patients with autism. And the more the answer pops up, yeah, brilliant. And you might find people overlap all the time and use more services than the others, then you'll find that the letters will appear much bigger, means that they're used more often. So it's really good to see a range of people that are being used. So we have the SALT team, CAMS, local authority, IAPT, BPS, ASD outreach services. Anyone think of anything else? Transforming Care Autism, brilliant. Nice to see lots of movement there. So local authority, yes. Green lights. Any more? Commissioning colleagues, yes. So use social work. So yes, using other colleagues that might be more happy to deal with service users with autism or a bit more confident. Community health, brilliant. Excellent. It sounds like we are using lots and lots, which is really, really good. So what I'll do is I'll stop for the time being. Oh, more. Should I stay on a little bit more, Ashika?
If they're coming through, yeah, maybe just another 15 sort of seconds.
Yeah, brilliant. It's quite exciting. Okay, so we've halted. So what I'll do is I'll go back and share and continue on with the presentation.
Thanks, Trang, for that. So without further ado, I will pass it over to Jenny and Jess to take us through the session on autism, children and young people.
Thanks, Ashika and Trang. Do you want to give me control of the slides? Is that all right, Trang? And then I can just flick through them. So, oh, you're on mute, Trang.
I did try. Can you do any? Can you see it?
Hold on. There you go.
It should let you now.
Yeah, it says I've got control, but I can't actually do anything. Oh, there we go.
Yeah, I can. Yeah.
Okie dokie. Can everyone see that now? Lovely. Okay. So hi everyone. So I'm Jenny Shaw. I'm a clinical psychologist, as Ashika said. And Jess, do you want to briefly introduce yourself?
Hi, I'm Jessica Ong. I'm the CCPL with Jenny for the LDA programme, and I'm a GP as well.
Lovely. So I'm going to start off today, and then Jess is going to kind of come in a bit later. And we're going to be talking about autism, and we're going to be kind of focusing on children and young people as well. So if you maybe kind of keep your questions for kind of when we pause, or kind of pop them in the chat and we can answer them afterwards, that would be great. So So as you probably know, autism is a neurological condition that affects the way a person experiences and interacts with the world around them. So it's estimated that about 1% of the population have autism, although I think we're not really sure. And actually, it's quite hard to get data on how many people have autism due to kind of, you know, diagnosis not being necessarily, the pathways not being there for some people. So around 20 to 30% of people with a learning disability also have autism. However, actually, when you look at how many people present to services, a lot of the people who present to learning disability services do also have autism. So it's sort of overrepresented in LD services. Another kind of term you might hear is neurodiversity, or someone saying they're neurodiverse. So some autistic people describe themselves as neurodiverse. There's a couple of video links in the slides, so we'll send the slides out to you. We're not going to play them today because we're not have loads of time, but you can look at those if you've got particularly kind of more questions about autism, but also they're quite good to kind of recommend to service users as well, or to families or other professionals. So if you want to sort of pass on the knowledge, you can kind of give out those links. So as I said, autism is part of kind of this kind of cluster of things we'd call neurodivergent conditions. So that's a term that's being used more and more, and so you'll kind of hear that term around, and that includes these other kind of range of difficulties as well. So just as a reminder, which we've talked about in previous webinars, but the difference between a learning disability, a learning difficulty, and a neurodevelopmental condition. So a learning disability is when someone's got a global impairment in cognition and functioning. So they require these kind of three elements to be diagnosed with a learning disability. So we're really looking at kind of a global difficulty in lots of different areas of life. A learning difficulty is a specific area of need, so it might be kind of dyslexia or dyspraxia. And then when we're looking at kind of autism, that is a separate neurodevelopmental condition. But as I say, they may overlap, and autistic people may have a learning disability, they may have a learning difficulty, or they might have no special educational needs at all. So it's quite a range of people we're talking about. Jess, do you want to go on for this one?
Great. So if we can go back one slide for just 1 second. Just something else that came up when I did this presentation to VTS yesterday is people wanted to know the difference between global developmental delay as well and how that all fits in. And by and large, we're talking about the under fives, and it's harder in that population to distinguish whether this is a permanent disability or not. So the term global developmental delay is used for the younger cohort. But once they have reached the stage where you kind of know that this is a lifelong impairment or disability in certain areas, it's better to move towards an LD coding or diagnosis because it opens up services. And I still see 30-year-olds with global developmental delay on their record. So it'd be great if you can all update that as you go. Next one, please. This is a very, very quick snapshot of the picture in Southeast London. So we've got females to male, 27%, 73%, and that is generally shared across all 6 boroughs. And in terms of prevalence, we've got small amounts 0 to 5 because it's harder to pick up, and a small amount in the over 65 because it probably didn't exist back then for diagnostic pathways. And actually the majority are adults, but then that's because there's a bigger age range. But our primary school and secondary school cohort is probably the majority of our service users at the moment in terms of people with autism. Bexley has the highest prevalence and Lambeth has the lowest. So that's that bit. Go to the next one. Okay, so this one is to do with deprivation. So here from 1 to 10 are the IMD deciles, and you can see that it's correlated with 2 and 3 and maybe 4. The vast majority are represented in the more deprived sections of society, and that's multifactorial, which probably don't have time to go into today. And then in terms of ethnicity, it's quite a good sign, actually, this graph, because it fairly accurately represents the population in the southeast, possibly a slightly more skewed towards the white ethnicity, given that the BAME population is a little bit higher, but generally speaking, we're not seeing too much underdiagnosis in the BAME category, so which is really good. Next. Back to you, Jenny.
Okay, lovely. Thanks, Jess. So just to go back to kind of what autism is. So as we said, it's a neuro kind of developmental condition, and I suppose it's we think of it as a kind of difficulty with communication and social interaction and interaction with the world around the person. So we're looking at a kind of cluster of difficulties. So the main thing we're looking at is impaired social interaction, social communication, and social imagination. So that's the kind of bulk of the diagnostics that we're looking at. There's also other aspects that we'd be looking at, including repetitive behaviours, restricted range of interests, and delayed or disordered language. So that's the kind of cluster of symptoms that we're looking at. So in terms of the kinds of specific things we might be seeing, so in terms of language differences, we're looking for things like delayed language, loss of words, echolalia, so that's repeating back things that people have said. Being able to kind of label pictures but struggling to kind of ask for things, kind of mixing up language or kind of not using gestures is one of the other things we look at when we're doing diagnostics. Social differences, we're looking at differences in things like eye contact, interactions, perhaps preferring being alone or kind of very non-imaginative play, difficulty participating in kind of conversations that go back and forth. So we often do something when we do diagnostics where we say something like, guess what I did this weekend? And the person might say, and they won't pick up on those kind of social presses. In terms of sensory differences, we may be looking out for things like picky eating, being sensitive to noise or crowds, disliking certain tasks like personal care tasks or kind of certain clothing, or even kind of certain sensations just generally, kind of the way people kind of navigate around their surroundings. So they might enjoy crashing into things or squeezing things, like weighted blankets. And then we're looking at kind of stimming behaviour, like hand flapping, jumping. We're also looking at repetitive actions, so preferring to do things in the same way, struggling with change, a preference for kind of that routine and familiar, kind of very routinized play, so doing things exactly the same way, or organising things rather than imaginative play, and kind of preferring certain kind of topics or toys, so kind of having quite a restricted range of interests. So that's just a few things. Obviously, there's lots of things that might come along with autism, but those are some of the things that we might be looking at. So you've probably heard the term that kind of autism is on a spectrum, and we kind of call it a spectrum condition. And I think people, we do think of it as a spectrum, and I think that is true to say, but I think if you look at the kind of the straight line, I think that kind of is a misconception of how autism is, and actually the visual on the right hand side is much more accurate in terms of people have different strengths in different areas and have different kind of areas of need. So it's not really a straightforward kind of spectrum. You can't be more or less autistic necessarily. It's just that you have a different kind of range of difficulties and strengths. So we don't really use terms like high functioning or low functioning anymore, and we don't use the term Asperger's syndrome either anymore. But just a few myths that we've wanted to sort of dispel about autism. So people can't grow out of autism. It's a lifelong condition. One thing that people say is that autistic people don't feel emotion, or perhaps don't like socializing, don't like other people. That's not necessarily true. Autism is becoming an epidemic is something that I think we've seen in the news recently, but actually what we know is, as Jess said, diagnostic pathways are improving for people. And so actually we know it's always been there, but it's just getting diagnosed better now. Autism is not caused by bad parenting or kind of those early life experiences. And one of the things people sometimes kind of cling on to, that there might be a cure, but we know that autism is not a disease and it can't be cured as such. It's now been kind of dispelled, this myth about vaccinations causing autism, that it's a childhood condition, because it very much goes into adulthood and can affect people for their whole life. As Jess was showing with the stats, there is an over kind of prevalence of kind of us seeing men or boys with autism, but we think that could have various factors involved with it, and it certainly does affect women, although maybe slightly differently, and that's perhaps part of the issue as to why perhaps boys are getting it picked up a lot more easily. There's also this kind of myth about autistic people having special talents or being savants, which is not necessarily the case. Some autistic people can have learning difficulties or learning disabilities, but not all of them. And again, that autistic people can be some of the most sociable people you'll meet. So it's not necessarily true that autistic people are antisocial. So in terms of sensory differences, there can be, the kind of hypo or hypersensitivities to each of the kind of the 5 senses that we commonly talk about. But we also talk about kind of balance or vestibular sensory stimulation and proprioception as well, which is sort of your awareness of your body to your surroundings. So there's actually 7 sort of senses that we're talking about. There's a little video link here, which we're not going to show today, but I'd encourage everyone to have a look at it in their own time. It's really interesting, and it sort of gives you a sense of how autistic people might perceive a busy environment and what they might be kind of focusing on. And sometimes autistic people really struggle to kind of filter out any background noises or any other things that might be going on around them, and they get preoccupied by their sensory experience. And that's when we might see some of those behaviours like stimming behaviours, so like rocking and flapping, as a way to try and manage the kind of over arousal that sensory differences might cause. So this is something we talked about in the last webinar about kind of behaviours, particularly behaviours that might be challenging. And we talked about behaviour being a way of communicating that something's not right. So I just wanted to remind people of this really, that what you might see on the surface is maybe sort of anger or disengagement or a challenging behaviour. But what we know is that underneath the surface, much like an iceberg, there's a lot more going on for that person. And what we try and do is work out what it is that is going on for that person. So it could be due to a variety of different factors. But usually we're looking at a mismatch between someone's physical and social environment and the needs that they have, which could be something really basic, like they're hungry or thirsty, but it could be something much bigger than that. We're also looking at unmet health needs, so we're always excluding that as a cause for challenging behaviour. And we're often thinking about someone's internal state, so how they might be feeling. And I guess one of the things is that when we're seeing challenging behaviour, it's often because the person doesn't have any other strategies to sort of tell you what they need or what they're kind of looking for at that time. So it's their only option. They're not doing it because they want to be challenging. They're doing it because that's the way they can get their needs met. It's functional. And we talked a lot about that in the last webinar. So if you want to know more about that, you can revisit that one. Just a brief kind of note that, you know, when we're talking about autism and learning disabilities, we're often talking about the negatives and the difficulties people have, especially because we're in a health setting. But actually, there's lots of strengths and positives that come with some of these conditions as well. And these are just a few of the kind of positives that people have kind of picked up on or told us about over time. And actually, I was doing a similar session with a family just yesterday, and they were telling me that their kind of loved one has a really amazing skill of remembering everybody's birthdays and important dates, and they think that's part of that person's autism diagnosis. It gives them that real strength there. So it's important to be able to acknowledge that, you know, autism isn't a problem necessarily. It can bring with it lots of strengths and lots of positive things. So just in, we're not going to go into loads of detail on this, but we just wanted to kind of put a few ideas on some slides about what reasonable adjustments you might be thinking about to support people with autism. So in terms of environment, you know, it's keeping in mind those sensory sensitivities a person might have and asking about that, and trying to make sure that your environments are autism friendly. Now, a lot of our environments aren't very autism friendly, but if you can set up even a space within your environment that is a bit more kind of not as overwhelming for people with autism in terms of their sensory needs, and it's kind of quieter, that is preferable. And I think that's the way that we're going to be going in healthcare services generally. In terms of communication, just a few tips here. So in terms of, I think one of the things that we used to ask people to do is give us eye contact, but actually what we're saying now is we don't necessarily need eye contact, and to kind of accept that if that's the person's preference, that's fine. Giving people lots of time, repeating key phrases, checking someone's understanding, using visuals as well. I mean, I like visuals just for me, so I think anyone kind of likes a visual, it helps understanding. And trying to reduce the amount of words you're saying and try and be a bit more concise with the words you're saying. So you're trying to get the same information, but with less kind of verbal communication. In terms of structure, as we said, people with autism like kind of familiarity and routine. So trying to keep things familiar for the person. So seeing the same person, perhaps on the same day of the week or the same time of day. Trying to use kind of prompts or kind of introducing it into their calendar, how they, you know, whatever calendar they use, they might have a visual schedule. So making sure that's in there in a way they understand and fits with the rest of their routine. We've got lots of clients who, if you interrupt their routine, that's a really big trigger for challenging behaviour. So trying to fit in around the person, basically. And understanding, I think it's quite a basic one, but actually goes a long way. So sort of knowing the person, knowing their preferences, not rushing, being friendly, kind of trying to relate your intervention to something you might know about them. So if they do have a special interest or a special skill, trying to relate what you're trying to say to them into what they already like and know. It can be really helpful. So often autistic clients know so much about things. They can teach you a lot, but also if you can hook what you're trying to say onto something they're already interested in, that can sometimes just be that key to success. Hey, over to you, Jess.
I just wanted to ask before we launch into this, because Jenny and I weren't really sure how much detail and whether we have clinical colleagues here or not, and whether the group wants to know that sort of slightly different signs in different age groups, or this is not appropriate. So we're just wondering if shall I go through it anyways? Okay, fine. So we're talking here about what autism might look like at different ages. First thing to say is toddlers, they don't present so early. Parents generally don't come along and say, I think my baby has autism. They generally is a bit later. First concerns are often around transition into nursery or preschool sort of age. And then a lot of these things are seen in hindsight. So the way the baby might have interacted or be overly passive, that sort of thing is often seen in hindsight. A bit of a red flag from a clinical point of view is if a parent reports regression of skills. That's something you want to really be referring early, and possibly not just to community pathways, but also to acute pathways, because you have to rule out other organic causes of regression. And it's very, very common for health visitors to also pick up signs because of difficulties in weaning and toilet training. Next slide, please. Thank you. And very, very similar, but a slightly older cohort, you might see a reduced interest in turn taking, and the play is slightly different. So, for example, lining up all their dinosaurs or all their cars in a particular order according to, size or something like that, or just being interested in the wheels part of a toy or something like that. And again, the intense focus, lots and lots of 4-year-olds are really into dinosaurs and can tell you the names of lots of dinosaurs, but it's about sort of exploring how fixated and whether every conversation is about that, and a different character to the intense focus. You might also notice playing in parallel as opposed to playing with each other, or some parents report just indifference to other children and just preferring to be with adults. We've already talked about our echolalia and words and sounds. Got to think about tics sometimes as well. And one really common thing is changing routines or change in scenarios really cause distress. So bedtime has to be exactly the same, or I only do this on Tuesdays, or this particular brand of chicken nuggets or something. And so we've talked about the sensitivity. It's just important to point out people are aware of noisy environments, but actually autistic people can be undersensitive as well. So the parents report going out without a coat all the time, or not responding to pain in the same way as others. So next slide, please. In terms of school, I'll just pick out a few bits of it, but separation anxiety, difficulties like bullying and controlling in play, things like very formal use of language or not understanding metaphors and being very literal. Many children at school are on the SEN register and might be poorly coordinated with dyspraxia, etc. And also eating and toileting at school tends to be an issue with the noise within canteens. In the masking cohort, which we're coming to next, if you can go to the next slide. So girls are generally picked up a little bit later. We covered a little bit about how they present differently, and most of that is to do with different types of social skills, and their special interests may be more socially acceptable. So I've met autistic girls who are really into makeup videos, for example, or TikTok or something, which is harder to spot as opposed to somebody who can name every plant in Hawaii or something. So the girls are more likely to receive a late diagnosis, and they're also more likely to mask, which means that they mimic others' behavior in the school setting, and the parents often report meltdown straight after school. And one of the reasons for moving away from high functioning and low functioning is that we now know the high functioning autistic individuals who mask are actually at greater risk of self-harm and suicide and having mental health problems. So even though they may function well in terms academically or in their speech, their overall function may be reduced due to mental health problems, etc. And the current tests are not very sensitive to female autistic traits as well. So I'm going to move us on because we're running out of time. Very quick few statistics. 42% of children have anxiety disorders, compared to 3% of neurotypicals. Epilepsy as well. And autistic children are 28 times more likely to consider or attempt suicide than neurotypical peers. 1 in 5 autistic women are autistic. 1 in 5 anorexic women are autistic. And we've talked about learning disabilities. 30% also have ADHD, and we know gender dysphoria is more prevalent, sleep problems are more prevalent, and also conditions like hypermobility, POTS, autonomic conditions, fibromyalgia, chronic pain. Okay. So this little last bit is about what we are doing as a team in SEL. So you will have probably all seen the autism framework. It's sort of a guidance on minimum expectations across the 6 boroughs. We would expect, for example, support post-diagnostically, to have pathways that is equal and accessible to all, that sort of thing. And each borough will work on their own local strategies based on the needs of the borough, because some boroughs have an older population and some have lots of under 5s who are autistic. So the key things we want to see in this upcoming year is that every borough will have an autism partnership of some sort. Everyone will have a different name, but basically a meeting where key stakeholders within the borough all come together to discuss priorities. And the paediatric core offer is currently being reviewed across SEL, and that is to reduce postcode differences and to try and streamline the offer. And we also have funding going to all 6 boroughs to up the pre and post-diagnostic support. And we are working on dashboards to try and capture some of the health inequalities. Thank you.
Thank you to you both. That was a really informative session, particularly on some of those updates, Jess, you give, and also some of the reasonable adjustments as well that we can all contribute towards and make in our practice during our consultations. Are there any questions for Jess or Jenny from the group?
There is no question in the chat box.
Okay, so we can move on, but please do feel free to type anything in the chat box. Tom is keeping an eye on this and we'll do a quick summary for us in the end. So I will now pass it over to David to take us through the next session on the Mental Capacity Act and deprivation of liberty in practice. Over to you, David.
Okay, hello everybody. Trang, I don't want to. Can you manage my slides? Is that all right if I just say next slide when we come to that bit? Is that okay? Thank you. Okay, hello everybody. That's me on that slide. So this is going to be a real whistle-stop tour. So next slide, please. Okay, so although we're really here just to learn about deprivation of liberty. I'm going to start off with the Mental Capacity Act. So we know, the Mental Capacity Act, that's the legal framework for how we make decisions for people who might be unable to make them themselves. We know from numerous reports and reviews that practitioners really struggle with the Mental Capacity Act. So I thought I'd just put a few top tips on that slide. I'm not going to go through them all, but first of all, really important just to clarify exactly what the decision is. That sounds easy, but it seems difficult in practice. And the actual tangible options related to that decision. It does help to understand if the decision is complex or not. That's not included in the Mental Capacity Act, by the way. But in practice, it does help because more complex decisions are going to need more of your attention as an assessor and decision maker. And this group is very much focused on things like medication. So if there was a decision about someone having, for example, sedative medication, that kind of thing is probably quite complex. So it is important to tease that out. People get really, I think, panicky about capacity assessments, but essentially it's a structured conversation that we'd probably be having with, or should be having with, all of our service users. So there's nothing to be scared of at all. If someone lacks capacity, we need to ensure we're following the best interest checklist. I'll just bring to your attention the first point about still considering that person's wishes and feelings. We don't just ignore the person if they lack capacity. So that's really important. And also we need to make sure we're recording it, because I think a lot of these conversations are happening, but the gap is that they're not being well recorded. So I've left a little link on there because the guide on the Lambeth Safeguarding Adults board, those top tips are from there. So whatever borough you're in, please feel free to access. Okay, next slide, please. Okay, so I just wanted to segue between Mental Capacity Act and Deprivation of Liberty. And really, so what I've just shown you, the top tips with the MCA, is all about, how we construct a care plan. And that's the first bit before we start worrying about deprivation of liberty. And so principles 1 to 3 of the Mental Capacity Act are essentially about supporting people where possible to make their own decisions. And theoretically, if people can make their own decisions, they're not deprived of their liberty. So it's really important to try and support people to make their own decisions about their care. Principle 5 is about the least restrictive option. Again, we will see this soon, but the freer someone is to do the things that they want to do when they want to do them, the less need there is for a deprivation of liberty authorization. So really, autonomous, free, empowered care planning is the start point, well, for MCA practice. But then we start worrying about deprivation of liberty. But we should be aspiring to good MCA practice. And I've just left a quote there by an eminent lawyer in the field of MCA law, and that thing, he says that whenever I hear him speak, and it's really important. Okay, so next slide, please. Okay, so you may know liberty is a human right, and human rights apply to anyone who are alive and are human. So that's basically all of us. And so Article 5 of the Human Rights Act is the right to liberty. And that essentially is a protection from the state's interference in our liberty. So the right to liberty is actually a qualified right. So that means it can be taken away in certain circumstances. So, for example, if a crime's committed, a person can be sent to prison, or if they have a certain mental health condition, they might be sectioned if they're posing certain risks. So it's not an absolute right. Okay, so additionally, a person could be deprived of their liberty if, firstly, they lack mental capacity to the decision about their accommodation. Secondly, if their care plan meets the test of continuous supervision and control, and they're not free to leave. And thirdly, if the state has some involvement in their care. So it doesn't have to be high level involvement. So if they're receiving NHS services or funding, local authority or the CQC is regulating the care home, that is all state involvement. But all three of those factors do have to be in place for there to be a deprivation of liberty. So the second factor has been the objective element. That was kind of developed through UK case law, a fairly famous case called Cheshire West, which people might have heard of. So that really broadened the understanding of what we understand about deprivation of liberty, and it effectively meant that a person doesn't necessarily need to be restrained or restricted to be deprived of their liberty. It could be a person could be totally compliant and happy with their care, but still those three criteria are met. So up until 2007, we had no legal process to authorise a DOL. So next slide, please. Okay, so this is a famous case in deprivation of liberty law. So HL was a 49-year-old man. He lived, previously lived at Bournemouth Hospital, which I think was an institution which doesn't exist anymore. But he went to live with Mr. and Mrs. Mr. and Mrs. E, under like I think today's equivalent would be the shared lives scheme. It was like a resettlement scheme. So as part of his care plan, he would go to a day centre in like local authority transportation. So one day, I think there was a change in route, and he became a little bit agitated that there was a change in route. And I think the driver maybe panicked a bit and took Mr. HL back to Bournemouth Hospital. And the doctors essentially kept him there. And this was in the days before the Mental Capacity Act. So they used common law to keep him at the hospital. So Mr. and Mrs. E were very upset with this. They wanted him to come home, but essentially they found out there was no legal challenge to the clinicians. After years, this eventually went to the European Court of Human Rights, and they identified that UK law had no appropriate process for authorising a deprivation of liberty, which, as I've said, is effectively around challenging a detention. And that's why the DOLS process was brought in. Next slide, please. Okay, so from 2007, the due legal process to authorise a DOL has been delegated from the Court of Protection to the local authority. So that's the DOLS scheme. So DOLS only applies to people in hospitals or care homes and who are over 18 years of age. So there's 6 assessments in a DOL authorization, but there are 3 main assessments which I've put on the slide. So the first one is an assessment of mental disorder, and that has to be done by a mental health doctor or Section 12 doctor, so it can't be done just by any doctor at all. Secondly, there's a mental capacity assessment, and thirdly, there's a best interest assessment, which is done by a best interest assessor who's a professional who's had additional training. So that a best interest assessor has to be a nurse, a social worker, an OT, or a psychologist. But as I say, they need to have done a specific course to be a best interest assessor. So the BIA provides that independent scrutiny of the care plan. A person who's under deprivation of liberty safeguards also has a right to an advocate. So this is known as a relevant person's representative. It's usually a family member, but if the person's unbefriended, then there's a paid relevant person's representative. And the role of that advocate is to bring to the attention of the court any objection by that person to their deprivation of liberty. So all objections to or all human rights cases are non-means tested. So a person can bring that objection to the court without having to pay for it. Okay, so we've seen a little bit about Cheshire West, or the judgment and the definition, and that really broadened out what we understand about deprivation of liberty and who it affects. So in line with the Mental Capacity Act that starts at age 16, people aged 16 to 17 can also be deprived of their liberty, as well as people who are in domestic settings. The DOLS with an S scheme doesn't cover those cases, so whoever might be a responsible funder has to take those cases straight to the Court of Protection for authorisation. Okay, so DOLS, there's so many criticisms. It's very bureaucratic. It's essentially seen as a rubber stamping exercise. So I think the statistics, there's so few BIA assessments which actually result in the BIA saying this person shouldn't be deprived of their liberty. After Cheshire West, the number of cases just went stellar. Basically, there were so many and the system just couldn't cope with it and still can't cope. And also the whole process is very sort of outside of practice, mainstream practice, and not very person-centered. So quite a few years ago, they looked about changing this. And so now we're going on to LPS, which is the next slide, please. Okay, so LPS, the Liberty Protection Safeguards, is essentially the replacement for DOLS, and seeks to improve on the system. The law for LPS was actually passed in 2019, but we still await for it to be put into place. So there's been so many delays related to COVID and various other issues. So we still don't have an implementation date, although we're beginning to understand more about what it's about, basically. So the key features are, so instead at the moment the local authority is delegated to authorise a deprivation of liberty, we're now going to have 3 responsible bodies. The NHS is going to make up 2 of them, with the ICB and our continuing healthcare responsibilities and NHS Trust. So they're really kind of like sharing the load. as I say, the assessments now, rather than them being done by a Section 12 doctor or a best interest assessor, they're really trying to incorporate them into mainstream care planning. So people who are actually writing the care plans, as long as they're registered professionals, may need to do the mental capacity assessment. And the third the third assessment, the best interest assessment, has been replaced by a necessary and proportionate assessment. And again, it should be the care planner who is doing that. Okay, so the BIA role has gone. We've got a new role, which is the approved mental capacity professional, who's essentially like a gateway for objections between the responsible body and the court of protection, trying to sort of sift out if there's anything we can do to alleviate that protection before objection before it goes to court. And then there's some changes as well with the advocacy. So essentially, with the paid advocate is going to be an IMCA now. So IMCA is going to broaden its role. Okay, next slide, please. Okay, so very briefly, so the NHS is now going to be a responsible body. So these are some of the things we're needing to think about in the ICB. So at the moment, it's around continuing healthcare. And some of the challenges with that is that continuing healthcare really does focus its work on eligibility. And so we need to start thinking about mainstream care planning and CHC. So that's a bit of a challenge because they're incredibly stretched, those teams. The way CHC works, the care plan is not always done by the ICB, so it could be another organisation that does a care plan on our behalf. So that's going to be a challenge. I'm sure this kind of the next challenge is will resonate with lots of people, but it's just trying to understand how we can balance different systems and implementing something new, cell-wide level and borough level, and thinking about different organisations. Because we haven't done deprivation of liberty for a long time, we're really there's a big practice and administrative gap, so we need to fill that. And just going down to the last thing, because I'm conscious of time, but although there's a lot of challenges, I think the way we work in our integrated care system does provide a lot of opportunity for some innovation with LPS. Next slide, please. And okay, so these are just some of the things that we've done so far. And I won't go through all of them, but I think essentially what we're trying to do at the moment is map out some of the processes, which I think we've done quite well in South East London. Then we're kind of like thinking of an in-depth scoping exercise. So once we've got the processes and the numbers, and I think that will give us the tools for thinking of some creative solutions, and hopefully we can do that between all of the responsible bodies. So we're really sort of streamlining the process for the person. Okay, that's the end of the presentation.
Thank you very much, David. And once again, thank you, Jenny, Jess, and David for the brilliant presentation. You will now see a QR code as well as the survey link in the chat box. So we would welcome any feedback on today's session or what you would want to know more about in the future sessions. So the key take-home messages for today is autism is not a disease, but it may manifest in a cluster of symptoms, and some sensory requirement has to be considered, but also be aware that some autistic people may also be undersensitive as well. So, and then like last time, we discussed about the behavior and communication. So we need to understand the strength that autism can bring and how people, autistic people may communicate via behavior as well. And finally, the co-occurring conditions in autism to bear in mind when you see anyone in practice. So just to ensure that reasonable adjustment can be applied for your patient specifically. And eventually we have the connection between mental capacity assessment and deprivation of liberty. So the criteria of those and the 3 main assessment required for those. Otherwise, there could be potential legal challenges as well. So thank you once again for everybody for joining us. Please use the QR code as well as the survey form to give any feedback for us. We look forward to hearing from you. Thank you.